forward to this. Okay. Let's see. All right, so here we have the PDF come out a little bit dark, some of these slides. So here's my contact information if you have any questions. We're talking about diversity today. Specifically, we can apply it to patients with psychosis and psychotic disorders. Just some general information, why we're concerned with diversity in our work these days, especially in the last couple of decades. It's because of the sheer growing number, absolute numbers of migrants and refugees around the world, as you can see here from general World Migration Report data and the UNHCR. And as we have more and more wars, it's becoming more and more of a problem. And as the absolute numbers of people are growing around the world, we are destined to encounter diversity, especially in larger urban centers like ours. We'll talk a bit about immigrants as well. People who are coming into Canada, newcomers, new arrivals, new citizens. The traditional wisdom is that immigrants tend to have less mental health problems compared to the general population, although this is a little bit contested terrain. If you evaluate immigrants more carefully and qualitatively, especially, you find that migrants of all kinds, even non-refugee migrants, suffer a lot of distress through the experience of migration. And one of the examples of this has to do with our field specifically about psychosis. As you know, that one of the most powerful predictors of new onset psychosis is a migration history. So migration is protective for a lot of medical conditions, not just mental health problems, but there are some problems that may predispose to even more. Another subgroup of migrants are refugees. We know that refugee mental health traditionally in literature tends to be worse than the host population, probably because of the adversity they face on their way to their new homeland. So you can read all kinds of information about this, especially rates of depression, rates of anxiety, rates of post-traumatic stress disorder. It only makes sense if you're fleeing political oppression or if you're fleeing other kinds of adversity, other kinds of discrimination. People often talk, I have to kind of present these kinds of ideas in any discussion, general discussion about working with cultural diversity in clinical practice. You have to talk about pre-migration, migration, and post-migration issues. So if you're working with migrants or you're working with diverse clientele in your psychosis clinics, this is an easy way to kind of think about asking questions or think about conceiving the problems that your patients are facing. You can talk about what happened before they came to Canada, what happened en route to Canada, and then what happened since they arrived in Canada. I think probably most of the time we focus on what's happening after migration to Canada because we're worried about their social adjustment to life in Montreal and Quebec and Canada at large. But if we don't really take time to listen to the pre-migration and the migration experiences, we'll miss a lot of important information that will guide our treatments and may even change our diagnoses. We may even discover that some of our patients really are better understood as not being psychotic at all. We may be suffering from various kinds of trauma, traumatic histories. What else do we look for when we evaluate people from diverse backgrounds? Language often becomes a problem. So not just French and English language, but many other languages we'll be presented with in our clinics as our patient population diversifies. It may be less common among the younger population, but certainly the parents and families of our clients will need attention to linguistic issues. And this means often finding linguistic interpreters that can help us. It's an extra step, it's an extra imposition, an extra bother, and it takes time away sometimes from our clinics. Generally, if you are seeing people with a linguistic barrier and you have an interpreter present or you're using even an online interpreter, you should allow about 50% more time for your evaluation or your session. There are many different kinds of interpreters. The one that we prefer in cultural psychiatry There are interpreters that are more toward interpreters as culture brokers, less kind of a medical, forensic, or political interpreter, where somebody's just kind of delivering word for word information. Say that's kind of less use in a clinical sense, because you kind of want an interpreter that's a little more connected to the client and can kind of give you a little bit of insight into their experience and a little bit of insight into their distress. And some linguistic interpreters can actually be promoted, can actually, you see that they're quite insightful, they're quite empathic, they're very appropriate. Some linguistic interpreters can actually be sort of graduated to give some cultural feedback. So you may take some extra time and ask those interpreters, how do you see, how do you interpret this person? Do you find that they're making sense when they talk? Or how do you, if you saw them on the street, what would you notice about them? Anything abnormal, anything unusual? And sometimes when you do that, the linguistic interpreter will tell you, well, I found them quite normal, actually. I found what they're going through and their behavior and their way they're talking quite appropriate for somebody who's been through their level of trauma or their level of experience. Generally, when we work with linguistic interpreters, I want to spend a little bit of extra time on this particular point. Uh, Again, kind of like the pre-migration, migration, and post-migration framework. When you're working with an interpreter, you talk about the pre-interview, the interview, and the post-interview framework with the interpreter. So interpreters really need to be we need to have a little bit of a discussion with them before you meet the patient, if possible. You can explain your expectations and you can get a sense of how this interpreter is going to be working. You can explain the rules that you want them to work by and collaborate with you. You can be more united. During the interview, you have to watch the interpreter as well as the client and make sure that they're comfortable. Some interpreters may hear stories and start to cry in the interview, or they may become very invested in the story and start to interrupt the interpreting frame, or they may be visibly upset or anxious. So you need to take note of that. And then after the interview, you can debrief with the interpreter, especially if they've heard a lot of traumatic or unusual symptoms. They may not be used to psychotic symptoms. They may not be used to heavy trauma stories. These are important aspects of working with linguistic interpreters. We talk a lot about culture and cultural psychiatry, and these are supposed to be cultural awareness seminars for clinicians, especially those working with psychosis. But culture is there are hundreds of definitions of culture. It's hard to know what it really means in the setting you might be working in. An easy way to understand culture is what Alan Young used to say all the time, which was the taken for grantedness of beliefs and practices and of a situation. So any practice or behavior that you or I participate in that we take for granted and don't question, we can assume that that's probably heavily culturally influenced. We often become aware of cultural differences when we meet people who don't share the taken for grantedness of our beliefs and practices. So, of course, many of our patients who come from minority backgrounds or who are migrants themselves or their parents are migrants to Canada, they're immediately forced into this awareness, a painful awareness that everything they took for granted or much of what they took for granted is up for grabs now and isn't so secure or certain any longer. So this is a very brief discussion of how culture, and a related aspect of culture is religion and spirituality, a generally neglected aspect of a clinical assessment. Many of our patients, especially those who are migrants, but many who are born in Canada as well, religion and spirituality is a fundamental aspect to their identity and also to their beliefs about health and wellness, and even about psychotic symptoms and treatments. So to neglect religion and spirituality is to avoid, for a lot of people, the very issues that make them who they are, and to take away from them what's most at stake with the symptoms and losses they're experiencing. So to inquire about religion and spirituality is an important subcomponent of a cultural assessment. This is a blurry picture of ancient tools. What kinds of tools do we have to work cross-culturally? One of the most powerful tools we can cultivate as clinicians is a concept called cultural humility. Cultural humility is something that we can learn. It's something we may not know much about. We may not be very culturally humble naturally as by our personality or temperament, but we can work to become more culturally humble. Cultural humility is a very important cause. Some people believe it's the most important quality of a culturally sensitive therapist or practitioner, more than any other aspect or issue or component of cultural competence that a person can learn. So cultural humility refers to a lifelong commitment to self-evaluation and self-critique, to redressing the power imbalances in the patient-physician dynamic, and to developing mutually beneficial and non-paternalistic clinical and advocacy partnerships with communities on behalf of individuals and defined populations. So what does this mean practically to you as you work with patients and families? It means that you know that you don't have all the answers as a clinician. And even though it's a rushed or time-stressed situation, that you try to let go a little bit of the medical or clinical agenda or hegemony, and you try to hear what's most at stake for the individual and learn from them what might be helpful. Safety is another core tool that we can learn as clinicians. There's cultural humility and there's cultural safety. This is a close second to cultural humility for the kinds of tools that we can learn as clinicians. Again, not all of us are naturally culturally safe. We may unwittingly impose some of our preconceived stereotypes or understandings about other communities or people or religious groups onto other people in our practice. We may not mean to do so, but we can strive to make our clinics and our offices and our practices more culturally safe. And what is cultural safety? It really arises from indigenous issues, indigenous values, and interfacing with indigenous people and recognizing the legacies of historical injustices that run through some communities and that structure their lives. So here's a quotation from Lawrence Kiermaier's work. Cultural safety is acknowledging the power imbalances inherent to clinician-client relationships and in the structural violence and inequality in the greater society. The clinical encounter can become safe by discussing these historical and social issues. So as a clinician, if you have a young Black man in front of you who's telling you about how he came to the attention of psychiatry by the emergency department and the police brought them there, it would be very appropriate to talk about the police and their experience of the police and what happened when they were in police custody, and to explain to them that the police and the Black community, as you know, as they know very well, have a long history of difficulty, and that you're there to help and to hear and to try to improve that problem so they don't run into those issues again. There are many other resources we can talk about. I want to go over these quickly to save more time for discussion with you and for your own clinical experiences you'd like to highlight today. But there is a very helpful, first of all, you can go to the McGill website about transcultural psychiatry, www.mcgill.ca/TCPS-YCH. There's also the MMHRC. You can Google MMHRC and it'll come up, the Multicultural Mental Health Resource Center. It's a website with a lot of practical information, not just for clinicians, for researchers as well, and for politicians and for policymakers. Every year we have an annual McGill Summer Program in social and cultural psychiatry and an Advanced Study Institute that are open to the public. Everyone can attend if you want. I can give you contact information for the program coordinator, Paula, who works at McGill. We have the Cultural Consultation Service at the Jewish General Hospital, where we can accept some cases that you might have. You might have a cultural question, a religious question, a linguistic barrier, or problems of racism or discrimination or migration. We can give some hopefully helpful input. I think the PEP Montreal and others of you have referred patients in the past on occasion. There's also the Culture, Community, and Psychosis Information Network, the CCPIN, which is an online resource specifically for culture and psychosis for clinicians and family members. This is the MMHRC website. This is an example of the summer program in social and cultural psychiatry. This is an example of the Advanced Study Institute, my personal favorite, Culture and Psychosis, from a few years ago. The McGill Cultural Consultation Service at the Jewish General. If you want to make a Cultural Consultation Service referral, you call Antonella at this number, 25655 at the Jewish General. And this is the C-SPIN information about psychosis for communities and professionals and family members. Let's talk a bit about practices for a few minutes. First of all, sorry, I'm racing along. I'm sorry. I'm going against my own preaching here. I'm coming out of share. Anybody have any comments or questions so far? This is kind of the background information, a very general overview of some issues around culture and mental health and clinical practice. Before we get into some practices and practical points, any comments or questions so far? Another question we'll be asking you at some point, maybe this or next seminar, is if these meetings would be better in person at the sites. So we'll talk about it. I mean, online has certain advantages, has certain disadvantages as well. So we're very interested in kind of talking about these issues in a way that's best for everyone, you know? So there, we'll kind of get your opinions on that. Some people are saying here, in person is always better. Okay. I agree. I mean, I love in-person things for sure. It's just that it's hard for some people to get there if it's in person, right? So we also do have kind of a linguistic issue, and the four sites that are collaborating for this project include the CHUM, the Clinique JAP at the CHUM, and a lot of people there are French speaking. So this session is in English. Most of these will at first be in English. We may do some on site there in French. If you think that's a good idea, any of you, please let us know. Yeah, online is eminently convenient, right? It's convenient, it's kind of practical, but you kind of lose a little bit in the interaction for sure. So I think we have to kind of try to balance these out. I'm going to go back to share if nobody has any burning questions. We have 25 people joining. I mean, it's far more people than I thought would attend or hear. I thought we'd get about maybe 8 to 10 people. Having a larger group is more difficult for discussion, actually, maybe. So that might be part of the issue too. I'm kind of just musing and reflecting as I go along. Sorry, I don't mean to be so informal. Here, I'll go back to sharing again. Okay, so practices, of course, the ultimate practice and culturally bound practice, Sigmund Freud's own psychoanalytic couch. Hold on a second here. So let's bring culture into psychiatric work. This is kind of a practical little mnemonic called learn, listen, engage, remember, notice. So the thing is, when I sent this to you, the first part, listen, the red one, was listen to migration stories. I've used this parts of this talk before for migration talks, but we're talking more about life stories about some of our patients may have migration stories. Some of them may have discrimination stories. Some of them may have other problems, police stories, or just misdiagnosis stories. So we don't know, but listening to life stories. So we'll go through this little mnemonic. It's not super new to all of you who are very experienced clinicians, but looking at it through kind of a cultural lens might be helpful. So listen to life stories. We talked already about pre-migration and post-migration factors as one way of listening to a kind of life story. You doctors hear us, but you do not listen to us. It is different. A refugee from Senegal. So we can talk about countries of origin with people. What if this was your country of origin? Talk about the migration journey. What if this was what we had to do to get to Canada? Walk for days through inhospitable or dangerous terrains. What if you had to land somewhere and barely survive? What if you arrive somewhere and people love you and they accept you and treat you kindly? What if you arrive somewhere and people are opposed to you coming and try to block your entry or try to hurt you? So listening to life stories is going to be important. and taking the time to do that, which is difficult in busy clinical practices, to take that time. But I think adopting a cultural lens means trying to sit back a little bit, finding some extra way to sit back and hear some of the life world of the patient and reducing a little bit of the voice of medicine, which is what we're all infused with constantly. And our patients react to that. A lot of people that may not respond to our treatments want more life world discussions. They don't want to hear just about the voice of medicine. In fact, the voice of medicine may be very confusing or not even appropriate for them in some cases, even though it may be true. There may be real medical emergencies. Because we don't engage them in the life world sphere, they may not participate or not accept us. We tend to call them bad patients or difficult patients. And I guess I would try to encourage us to pull back and try to just think more in terms of misunderstood patients or people that are hard for us to love or appreciate. How about engage cultural resources? We have a lot of cultural resources that we can engage. We have linguistic interpreters at most of our institutions that we can hire, or at least online, if not in person. Some institutions don't pay for linguistic interpreters. I think it should be a point of advocacy for all of us to make sure that we have access to linguistic interpreters paid for by our institutions. For certain difficult situations that may require more cultural understanding, a culture broker or interpreter may become necessary. If you have questions about that, you can contact Antonella 25655 at the Jewish General. She can give you advice about who to maybe contact for cultural brokerage. You can engage families and community organizations. So interpreters and culture brokers, they're kind of linked together. As I say, linguistic interpreters can become culture brokers because some linguistic interpreters have an extensive understanding of the culture of origin of the clients that you're helping, that they're sitting face to face with. Some linguistic interpreters are not appropriate. They don't follow the structure that you need them to follow in the clinic, but they still may have important information. You can watch what an interpreter does and how they interact in the waiting area before they come to see you and how they're talking to the patient. You can see here the interpreter is engaged quite closely with this woman. And I would definitely pull this woman aside after and ask how she found the quality of her speech, how she found her behavior, her education level, and other questions, and what kind of language she was using in her country of origin. Is it an educated language? Is it a working class language? Those kinds of issues. You don't have to be told this as members of first episode psychosis teams. You work with families all the time, but a lot of people in psychiatry don't. And for a lot of people around the world, migrants and refugees especially, leaving the family outside in the waiting area is almost offensive, if not completely disorienting. So a lot of people don't work very well in an egocentric system or model, which psychiatry unfortunately espouses too much. They work more in a sociocentric or family-centered model, or even community-based or ecologically based system. So families need to be engaged every turn. I think you do this very well already. For me, I always do a first intake, whether in early psychosis or cultural consultation with all the family members present that I can muster. And then if needed, I can have people leave the room. I can have the family leave. I talk to the individual, but it almost always starts as a family intervention and an assessment. We, in cultural psychiatry work, we try to engage communities as well, because families are just a part of a community and a society. So it may be hard to know how to engage communities, but you can ask permission to do this. And through the conversations you have with your clients, they may indicate members of their communities that are important to them. They may or may not be religious leaders or religious members of their communities, but some people sometimes, when they come to Canada, may live in a religious institution for several weeks or months as they await processing as refugees. So these kinds of things are very important to know, and communities can provide networks and resources to you as clinicians. So if you can access families and communities early on, so much the better. Some people come to Canada, they're totally isolated. Some people that we see with psychosis are totally isolated. They don't want any contact with their families. I understand that those are clinical realities, but this is an orientation to the clinical work. So we're trying to include families as much as we can. We're looking for opportunities for families and communities to become part of our work. Okay, so this is the third part of the learn mnemonic. LE, so we talked about engagement. R is remember special populations. So we work with children, we work with youth a lot in early psychosis. So early psychosis is important. Women are a special, we don't work with elderly very often, although sometimes we have grandparents or elderly parents who might come in some of our meetings. So these special populations, what's happened to our early psychosis patients in the past? Have they been separated from their parents? Have they experienced gender-based violence? Are they starting all over again in an unfamiliar society and culture? This is frequently the case in the kinds of patients we see, or at least for their family members. Notice common mental health problems. So we all work with psychosis, it's true, psychotic disorders, but there are other kinds of comorbidities that may be common. If some of the people we're seeing are refugees or migrants, PTSD and anxiety or depression may be part of the picture, but it may be other kinds of problems. It may be autism spectrum disorder, maybe borderline personality disorder, maybe other kinds of psychiatric conditions that are commonly misunderstood to be psychotic disorders, or they may be co-occurring with psychosis. So we need to always pay close attention in our diagnostic process to kind of untie and unravel some of this complexity. I think adopting a cultural lens can be helpful. Sometimes it can be confusing. We may not know culturally what we're seeing. I just got back from Mexico City. I'd never been to Mexico before. It was for a World Psychiatric Association. And I was driving around. I was just commenting to my wife. I was saying, I don't know any of the cultural reference here at all. I feel totally lost. I don't know what that crowd gathering means. I don't know why there are armed men standing outside that building. I don't know anything. I'm kind of lost. So it just was helpful for me to be in that position again, to remind myself what it means to be in a new culture, to not be taking for granted the things around me, and that includes diagnostic categories. So losses are important, and trauma, of course, for some of our patients are very important, and not just trauma in foreign countries outside of Canada, but trauma by the police, trauma in the emergency department, trauma in their psychiatric care and treatment can be very important. I mean, you probably have patients like I do who, to me, they seem to have a pretty classic psychotic disorder, but to them, they tell me that their problem is post-traumatic stress disorder. And then they tell me about when they were restrained in the emergency department and had a very bad experience being given forced medications. So that's how some of my patients understand their psychotic illness. Whereas I'm looking at them, I see that they have florid delusions and paranoia and so on. So let's put it all together then before we turn the time back over to you, talk about some of your own questions or cases. Because I don't really, I mean, I have cases I can share, but I don't think it's necessarily the best way to go. So LERN, the learn mnemonic, listen to life stories, engage family and community resources, remember our especially vulnerable populations, and notice common mental disorders that might be co-occurring with psychosis or maybe complicating the diagnosis. Okay, I think that we'll skip over my particular cases here. You can go back to them if necessary and just kind of have a bit of a concluding slide, looking at the diversity of the wonderful and amazing diversity we all encounter in our clinical work. We're so privileged to do this. We're so privileged to be in a place where we can hear stories, hear the struggles people are having, be in a position to be of help to them, to listen to them maybe for the first time in their native language as they speak through an interpreter, as we give them that time and grace to have that opportunity. We're interested in diversity. We're interested in cultivating a sense of humility, cultural humility and safety in our practices, in our attitudes. We're carefully attuned to the linguistic needs of our clients and of the cultures that they come from, their religion and spirituality, how that affects their lives. Is that something at stake for them, of importance to them, or is it something they don't care about at all? They don't need to talk about. We're aware of cultural tools like cultural humility and cultural safety and practices, as we've talked about, the learn mnemonic, to listen and to engage and remember and to notice. So I'm going to come out of this presentation. I've thrown a lot of stuff at you. We have about 15 or so minutes. And I'm just going to leave it to you guys. If you have some questions, concerns, if you have clinical vignettes you'd like to share or clinical questions you might have, we can spend time discussing that. If not, we can end early too. It's totally up to you. Oh,
Eric. Hi, Eric.
hi, some of you are in the chat and you
Yeah.
can't you can't comment, you're saying, because it's my mic isn't working and stuff. Well, I'm sorry about that.
Can I
Yeah,
make a comment?
yeah, the slides were sent to you. I think I can send the new one. I made a few changes to some of them. Yeah, sorry, Howard. Go ahead. I cut you off.
No, go ahead. It's no problem. So yeah, first of all, I want to thank you for organizing this discussion and this presentation. I think just having the opportunity to reflect and think about our practices and how we can improve ourselves and become more adaptable is important. And so thank you for that opportunity. And I think this is always going to be a work in progress. This is not something that we're going to sort of ever master because there's each person comes with their own story, their own culture, their own background, their own biases as well, and so the best we can hope for, I would think, is that we're adaptable enough so that we can best be helpful to the person in front of us.
I think that by talking like that, you're a long way there. So that's an that's an important thing to notice. I think you're right. I mean, it's a work in progress, right? I mean, that's the whole thing. And I mean, everybody has failure moments. I mean, when I'm in the emerge, I see a patient, a young black man's presented to me in the locked unit. I have to make a quick decision. I have five other people to see. Do they stay? Do they go? He pleads to be let go from the emerge. I say to myself, wait a minute. I'm a white psychiatrist. I'm interviewing a black maybe psychotic patient. And then I do the closed treatment order. You know, the garden they have these small. There are moments like that where I go, wait a minute, I can't seem to come out of this entanglement, this sort of repetitive cycle that I keep finding myself in. But at least questioning it and thinking about reflecting on it, I think we can find ways to make it reduce getting bound into those problems. And certainly in the outpatient department, we have a lot more leeway. In the ER, it's often a lot more constrained. So no, I like what you're saying. And I think just recognizing every case is so unique, and then giving the time it takes. I mean, I think time pressure is where a lot of issues and problems arise. And when we go back and I look and I say, what did I say in that consult? I look at it and I go, oh, that was tough. I only had 15 minutes, or something like that. So yes, I appreciate that. That's great. I mean, thank you for bringing that to our attention. I think that I'm not sure your first name. I've seen you before. Langevin?
Langevin, Louise.
Louise Langevin. Yeah, did you had a comment too?
Um, there's so much I could bring up, but don't know where to start, but I'm certainly very, very sensitive to culture. I'm French Canadian. I converted to Islam. I wear hijab.
Mhm.
There's in my clinic here at PEP, Dr. Margulies is Jewish, Jonas is Christian, I'm Muslim, converted Islam. So we have cultural staff, we have where patients identify to us somehow. But I don't speak Arabic fluently, but I know I live by Islamic practice, so it it's on that too. I've often been consulted, even when I wasn't in PEP clinic, about families and how they view their young one. Suppose if the Muslim family rejects their young one because they're homosexual
Mm.
or trans culture, trans issues, and the Muslim family is kind of rejecting the person, but I don't have an answer to that.
Right.
But so
Well,
so
that's a really important question. I mean,
yeah,
we see in cultural consultation, at least, maybe not, sometimes in early psychosis, that is a reason for people to come to Canada is because of sexual orientation and the brutal treatment they've received in different parts of the world. They've come to Canada to try to have a fresh start. So I mean, I think that's an issue, and how to talk to families about sexual orientation, like psychosis, is very complicated. Not everybody believes the same way.
e-
So,
exactly. And the Islamic views on this is very different from the flow of the population.
mhm,
So to how to situate ourselves uh, as a Muslim and as a professional,
mhm.
and to respect everyone's views and help the person.
Yeah,
It becomes very oh anyway, lots of issues within me being a
yeah,
practitioner, like practicing with my own values as well.
yeah. I, I
No,
I love what you're saying because you're bringing our attention to us as clinicians.
yes,
Culture isn't just out there. It's not just in other people.
no,
We are embodied cultural beings, right? Wherever
exactly.
we walk, wherever we speak, whatever we do, we're flowing, throwing off cultural symbols and signs and communications. So this is an urgent matter for clinicians, is to understand what cultural signs and symbols you're throwing off all the time. Very important thing a very important self-reflective point. I'm glad that you brought this in.
Well, like homosexual staff will say, well, support me because I'm different. So I would know what it's like to be different
Mm.
in the environment. And
Hmm.
so I kind of have a support from them because I'm different too. So I have to face people, and
Yeah.
people look at me and judge me or whatever. But anyway,
Sure.
that was, and also in the inpatient in the 90s, I remember it being, I was scared maybe patients would be delusional, more delusional, but it was
Yeah.
actually very neutral.
Hmm.
Uh, Patients that would be jealous of a person, a staff member being sexy, and the patient will respond very neutral and have a religious side to them that they would open to me.
Hmm.
There's
Hmm.
been a lot of benefits as well. Um, but I have a lot of questions of my reflecting on my own practices, and then how people come to me with their own. And
Uh-huh.
yeah, it's but
Yeah.
I find my team as a variety as well, you see. So
Hmm. That's
as
good.
yes, the psychiatrist named me for a Muslim girl to say, I have a nurse who wears hijab in the clinic. And so she's kept coming. She
Right.
wouldn't stay before,
That's right.
but she didn't come yesterday. So I don't know.
They don't
Oh,
come no matter what, right? They don't come no matter what. I mean, this is so important. I mean, when I walk into a room, like what do I say to everybody? Everyone goes, "Oh, establishment psychiatrist." Here I am, white, middle-aged kind of person. So this is the so I'm aware of this. So it puts horrible limitations. So for many patients, it curries maybe favor with some, of course. But for some patients, I'm immediately, whoa. So I have to work in a different way. You have to work in a different way. And we have to be, you kind of have to learn how people are responding, and then you start to work along with that in mind. I mean, this is a fundamental part of this discussion. I think
We
we,
have yes,
we
we have a question from Nicolas from PEP Montreal about translators. If we have no choice, can we legally use family members or interpreters?
okay, great question. You mean that if you have no choice, like your institution won't pay for it, you mean? Is that kind of the bottom line? I mean, or if no one's available, maybe. Yeah, I mean, I use family on a case. I try to never use family. Like, why do you think using family members would be problematic as an interpreter? Anybody have any ideas?
Well, they're not going to necessarily they're going to give you their interpretation of the story. They're not going to give you a verbatim, report of what the patient is saying necessarily.
Yeah, exactly. Someone said here they could also lie. Do people ever hide the truth? On occasion, right? If I'm talking to people about my family, I kind of avoid the parts I don't want to say and say the things that are going well. So this is kind of how people are. Yeah, to fit what they want to believe about their loved ones. Yeah, for sure. And so this is just a human nature. I mean, the closer you are to somebody, you're kind of reluctant maybe to share very ugly or, of course, ugly, but even just difficult parts of your relationship. I mean, what about abuse? I mean, what if the interpreter is an abusive member of the family to the person that you're evaluating? I mean, this is a real possibility. It could happen. So you have to be very, or what if it's a child? I mean, you sometimes might call upon a child of a family, a younger person, even an adolescent, to interpret very mature material about their parents. I mean, that's not appropriate. So on occasion, you do have to do it, and you try to proceed as best as you can. Choose a member of the family that seems to be capable of that responsibility, and then you don't be too strict with them. You let them kind of say what they're saying, and you might debrief with them after about what they said, if there's anything they wanted to add alone or privately. But usually we try to go with professional interpreters of one. I prefer in person. I know that a lot of people do online interpreting now, but it depends on the delicacy of your evaluation. An online interpreter may not be sufficient for some kinds of interviewing. So go ahead, Louise.
I was wondering through the talk, I didn't catch what is a cultural broker
Uh-huh.
rather than interpreter,
Yeah,
linguist, cultural broker. I don't know what that means.
yeah, thank you. I kind of glossed over it in the presentation, but a culture broker is really a kind of an interpreter. You can have interpreters that are very legal or forensic or political, who kind of they specialize in translating verbatim very quickly everything someone says. And then you have other interpreters that are a little more interested, not in a verbatim interpretation, but they're kind of telling you a bit about how they feel and what they meant to say and stuff like that, right? They're kind of a little more interpretive of the interpreting. Those are people that are a little more toward a cultural interpreter. A strict cultural interpreter would be somebody who's not interpreting language. You'd have a linguistic interpreter doing that. A strict cultural interpreter is somebody who'd be listening for cultural behaviors and beliefs that may not be understood by the clinical team, and they're giving you context. Like, for example, let's say that a woman is avoiding eye contact of me, the male psychiatrist in the room. And I'm thinking, oh, autism spectrum, or, I don't know, something like that. And then the culture broker at the end says, what a respectful woman. She wasn't looking directly at you to show how respectful she was of you and your authority. And I go, oh, okay, great. I'm not going to jump to any conclusions about some other kind of diagnosis. So a culture broker is interpreting those kind, but in practice, a lot of linguistic interpreters blend with culture brokerage. Some of the better interpreters kind of blend and give you a mix of linguistic interpreting and some cultural insights as well. So that's a good question.
So that's how you differentiate. Well, it's still interpreters, a broker, but they're more
Yeah, they're more
bigger view, a bigger.
Yeah, they're more interpreting sort of is the person's behaviors or beliefs or speech culturally appropriate? Is it given the cultural context, is it more of a norm? Can it be normalized, or is it
Where,
really out of
yeah.
line?
Where
Yeah.
can you find these people to
Ah,
come?
that's a very good question because they're not hired by the Regie. We use them as interpreters sometimes here in the ICFP. But you can, if you need to have a list of culture brokers, you can contact Antonella 25655 at the Jewish General. We do have a database of culture brokers we've used for the past 25 years. Some of them are not as active as they used to be, but some of them are still could still be called upon. Some of them may do it voluntarily because they're students or they're somehow involved in their training. Others may want to do it voluntarily because they might be like an anthropologist from McGill who specializes in Mexican culture. They're interested to be involved. They want to go out and do help like that. Other people may need payment because they're newly arrived in Canada. They don't have any work. So it kind of goes case by case for us with our culture brokers.
Okay.
Sorry, there's some other hands and comments. I'm letting
Yeah,
Sandra guide the comments.
Okay. Well, we have Natalie with the hand up
Okay.
while I look at the comments.
Mhm.
Well, I just wanted to ask, I'd be very interested to know what because as a family peer support worker, my role and is solely working with families and caregivers and what the impact, the cultural impact is on recovery for a patient. Because I work with a lot of families who, for example, have views that are so set in stone that are also generational, but cultural, like we escaped the war and, been through so much trauma and come here
Mhm.
and we are okay, whereas our loved ones have everything and grew up in, a space where there isn't war and are not, or cultural expectations of the role of that person, like children, will take us in when we get older. We wouldn't go to a CHSLD, for example, but they will take us in and care for us. And so there's all these kind of expectations of roles and dynamics in families. And I wonder that are hard to work with. It's hard to support a family member who has that set in stone view, or even the idea of self-care not being something that's a priority at all, of taking care of oneself, but actually rather being a productive member of that family or of society, no matter what
Yeah.
struggle you live with. So I wonder what the impact of that is on recovery and a person's ability to recover when their families have these views and expectations of them.
Very excellent question. I can see you have a lot of experience in this for these kind of dilemmas. So my quick answer would be it has maybe not everything, but maybe everything to do with recovery. If a person has no family, they've lost their main allies in society and culture and community. If they have a family that is not understanding them, it can be damaging. If they have a family who's not just supportive, but understanding and guides them to timely care, and encourages appropriate interventions, it conveys a huge benefit and a positive association with recovery. I'll just give you a very quick example. A patient that I saw from a religious community had severe schizophrenia. And the consultation was, how can we help this person? Because the parents have a different view of how this person can practice their religion. The young man said he wanted to pray, he wanted to perform all the rituals and participate in the religion, but he couldn't because the voices were so severe. And the parents thought that he would, if he just applied the religious principles better, he would heal and do better, like their older son had done years before. So after discussing with them, it was appropriate to invite a religious leader to come into the consultation. The religious leader and I spoke at length with the family and the young man. At the end of the discussions, the mother accepted the illness, but the father thought we were undermining his patriarchal authority. So that was kind of the ambivalent outcome that we weren't hoping for. But it was one, but it worked to some degree. It gave the young man, I think, some more room in the family to still be an acceptable member. So this is how it goes, and this is how you can bring to bear these family interventions, try to modify expectations and improve clinical understanding while respecting belief systems at the same time. We didn't mean to undermine his authority, and the religious leader said that he would follow up independently with the couple to try to amend any problems that had emerged from the consultation. So I hope that's helpful. Are there any other comments? Our time's up, isn't it?
Yeah, we have a comment about translation. If it is, what about using AI-powered tools for live translations?
Yeah, I think we're not there yet, but maybe one day we'll get more powerful AI. I mean, humans find this very complicated and difficult, so I can only imagine how machines will find it. I mean, machines can do some things, of course, extremely well, crunch number data and so on. When it comes to the very vehicles of human communication, including linguistic expression, empathy, insight, and those kinds of human dimensions, I'm not sure how that's going to work, but I wouldn't rule it out for sure. AI is getting more and more powerful. Maybe there's a way for tools to eventually be integrated into what we're doing. It's probably not a very satisfying answer for those of you who are very AI knowledgeable. So let me just share one last thing here. I'm so sorry to do this to you. I want to come out of this presentation mode. Before we leave, you guys have all been so patient. Let me share again. I have it here still. Yeah, I do. The next of these seminars is not going to be me. It's going to be Charlotte Wint. She's an amazing psychotherapist from the Black community. She's extremely sensitive and insightful and knowledgeable. And she has a lot of experience to share. She's actually worked as a culture broker with the Cultural Consultation Service in the past. And just so you can all see it here, she's coming up on December 13th, right here, Strategies for Improving Service Delivery to Members of Black and Cultural Communities. December 13th, 11:30 a.m. Again, if you can write into us and tell us if you think this is a bad time, other times are better, let us know. But I mean, we had more people here than I thought, 25 or so. So we might continue at 11:30 next time and see how it goes. Okay, I think that people have to go. Thank you, everyone.
Thank you so much.
All right, see you soon. Bye.
Bye.
I hope you're safe. I hope that your mic is working next time. That was difficult.
la portion. Là? Ouais.
So I think you can stop the recording.